Clinical Cranial Neuropsychology 1A Cranial Nerve Thinking Dysfunction. Explaining different symptoms of NPD. NPD Hello. I'm Dr. Jacen Lee, a clinical psychologist and clinical neuropsych from the perspective of clinical neuropsychology and cognitive neuropsychology. A detailed analysis linking the neurological dysfunction of Narcissistic Personality Disorder (NPD) to its symptoms. 1. Neural basis and symptoms of thought patterns. 1. Neural mechanism of grandiosity. Prefrontal cortex PFC dysfunction. Ventromedial prefrontal. Cortex vmPFC is responsible for self-evaluation and reality testing. Patients with NPD experience reduced gray matter density or dysfunctional connectivity in this area, leading to impaired self-monitoring and an inability to correct unrealistic self-perceptions. Hippocampal memory integration bias, dysfunction in the hippocampus, causes patients to selectively strengthen memories consistent with self-aggrandizement and ignore contradictory information. Symptoms: patients believe they are unique and overestimate abilities, even when there is a lack of evidence, e.g., claiming to be a genius without actual achievement. Example: an NPD patient may claim to be fluent in a foreign language in just 3 days, but never engage in learning. 2. Neural mechanisms of privilege. Orbitofrontal cortex OFC decision-making. Deficits. OFC's dysfunctional integration of risk and reward makes it difficult for patients to predict the consequences of behavior and reinforces the belief that do as you please is necessary. Overactivation of the ventral striatum reward system. High sensitivity to social status-related rewards such as adoration, driving patients to demand perk. Symptoms: believing they should be given priority access to resources, even when breaking rules. E.g., declaring my time is more valuable than others when jumping in line. Example: NPD employees may ignore company rules, ask supervisors for extra vacation days, and threaten to leave in order to obtain a compromise. Neural basis of emotional responses and symptoms. 1. Vulnerable self-esteem neural mechanism. Weakened prefrontal limbic system connectivity. The prefrontal lobe has insufficient regulation of the amygdala, resulting in amplified and difficult to calm negative emotions such as shame and anxiety. Overactive default mode network (DMN). DMN is associated with self-referential thinking, and overactivity may trigger regurgitating negative self-attention, e.g., do others approve of me? Symptoms: minor criticism can trigger a strong sense of shame, which translates into anger or aggressive behavior. For example, when a significant other advises an NPD patient to speak less sharply, the patient may become angry and accuse the other person of being jealous of my eloquence. 2. Neural mechanisms of shallow effect. Disability of the anterior eyelid empathy network. Decreased gray matter in the anterior eyelid leads to low emotional empathy, which can only interact through cognitive empathy, rational analysis of other people's emotions. Abnormal mirror nerve cell system (MNS) function. MNS is responsible for imitating other people's emotions, and its insufficient activation makes it difficult for patients to truly feel the pain of others. Symptoms: the sadness of others can only be rationally comforted, such as condolences, but not sincere care. Example: NPD significant other may calmly analyze "you should have changed jobs" when the other party is unemployed, rather than expressing support. 3. Neural basis of behavioral patterns and symptoms. 1. Exploitation and manipulation. Exploitation neural mechanism. Low inhibitory function of the dorsolateral prefrontal lobe (DLPFC). DLPFC is responsible for suppressing impulses and moral decision-making, and its weakened function makes patients more prone to taking advantage of others. Sensitization of the ventral striatum to social domination. Exploitative behavior can quickly activate the reward system and strengthen the motivation to manipulate others. Symptoms: deliberately befriended powerful people for profit and quickly abandoned each other after the relationship ended. Example: an NPD supervisor may falsely promise a promotion to a subordinate, inducing them to work overtime, only to take credit for it later. 2. Retaliatory aggression, vindictiveness, neural mechanisms, hyperresponsiveness of the amygdala. 2. Hypothalamus, hypersensitivity to threats such as criticism in the amygdala, combined with the combat response of the hypothalamus, drives retaliatory behavior. Anterior cingulate gyrus ACC, conflict monitoring dysregulation. ACC is supposed to regulate impulses, but its dysfunction makes it difficult for patients to suppress aggressive impulses. Symptoms: extreme retaliation for minor offenses, e.g. spreading rumors, and slandering colleagues for correcting their mistakes. Example: an NPD student anonymously accused the professor of academic misconduct online after being corrected by the professor for flaws in the paper. 4. Neural basis of social interaction and symptoms. 1. Neural mechanism of instrumental relationships. TPJ defects in theory of mind. TPJ is responsible for inferring the intentions of others, and its dysfunction makes patients perceive others as tools to meet needs. Abnormal dopamine release in the ventral tegmental area VTA triggers intense dopamine release only when receiving adoration, leading to an addiction to utilitarian socialization. Symptoms: contact others only when resources are needed, and usually do not carry G. Only contact industry contacts when applying for a job. Example: people with NPD may give generous gifts to friends in exchange for promoting their cause. 2. Pathological envy, neurological mechanism. The ventral striatum is more socially sensitive. The achievements of others trigger a sense of relative deprivation in the ventral striatum, rather than a motivational response in normal people. Failure to integrate the prefrontal limbic system. Failure to regulate anxiety caused by jealousy, which in turn degrades others to relieve discomfort. Symptoms: belittling the achievements of others, e.g. acid, he got promoted just by flattering, even if the other person is a relative or friend. Example: a mother with NPD may criticize her daughter for just being lucky to get into a prestigious school and refuse to attend the graduation ceremony. 5. Integrative model. How neural networks imbalances maintain the symptoms of NPD. 1. Self-regulatory network dysfunction, prefrontal limbic system connectivity abnormalities, leading to a vicious cycle of cognitive bias, exaggerated self, and emotional dissonance. Fragile Self Esteem. 2. Empathy reward network distortion, ventral striatum activation imbalance. In the anterior eyelid, empathy deficits prevent patients from forming authentic connections and overly rely on external recognition, such as worship, to fill internal voids. 3. Threat defense system hypersensitivity, predominance of amygdala hypothalamus. Interpersonal interaction is seen as a potential threat, and aggression or manipulation is used as the default defense strategy. This model explains why NPD patients hide deep insecurities under superficial arrogance and have difficulty modifying behavior through experience due to impaired neuroplasticity. Future research will use cognitive behavioral therapy to correct the function of specific brain regions. I hope today's sharing can inspire you. See you next time.